everyone. Welcome. Welcome and happy Friday. We've got a lot of happy folks in the room today. I'm Diana Martin. I'm the Executive Director here at Hourglass, and I'd like to welcome you to today's First Friday Forum on Lancaster's community health needs. Today we're joined by Alice Yoder and Brenda Buescher from Penn Medicine, Lancaster General Health, and Michele Mummert from WellSpan Health. Their two institutions recently completed community health needs assessments to identify and prioritize the health issues that are most important to our community. In today's presentation, they will share key data points about what they found, as well as how both health systems plan to address these issues with their community health improvement plans. After their talk, we'll have time for questions from you all and also everyone who's joining us on the live stream today. If you are joining us on the live stream, just drop those questions in the chat and I'll be monitoring them. Thank you so much to our presenters for being here, and I'd also like to thank our First Friday Forum sponsors, Rogers & Associates, and the Ware Center and Millersville University for hosting us today. Thank you. All right, turn it over to you all. And you have the clicker right there.
Hi, everyone. Good afternoon. My name is Brenda Buescher, and I'm a health promotion specialist at Lancaster General. I specialize in data collection, needs assessment, and evaluation, and so I'm going to share the highlights from our 2022 Lancaster County Community Health Needs Assessment. The first thing that I'll say is that every nonprofit hospital does these community health needs assessments for their own service area. So we define our service area at Lancaster General as Lancaster County, and so our CHNA is Lancaster County. WellSpan has a broader service area, so Michele will talk about their CHNA and their Community Health Improvement Plan, which cover several counties, but we jointly publish this Lancaster County report and work together because our service areas overlap here, and we've done that for many years. What is a CHNA? A Community Health Needs Assessment is a tool used by public health departments and, like I said, nonprofit hospitals to identify and then prioritize what our community health needs are. And this is done involving the community. That's very important to us. And then it leads to health improvement plans. So what do we plan to do to address those needs in our community? We use many different methods to gather data for this report. So the first thing we did was looked at existing community reports. We looked at things like the Lancaster County Comprehensive Plan, the Office of Aging Strategic Plan. The state had an LGBTQ health needs assessment that was really helpful to us. We didn't want to duplicate work that people had already done in identifying needs for our community. Then we went and talked to community leaders, and we talked to people who were leaders in different sectors like business and education, and also who were leaders in different populations within our community. So we wanted to understand what needed to be done to make sure that everybody had an equal opportunity for good health. So we specifically wanted to talk to people who worked with communities like our Plain community, refugees, our Black and Latino communities, and other kind of groups within the population. Then we did secondary data gathering, which is statistics that you would traditionally think of as health statistics from the CDC and the Department of Health. We did a community survey and gathered input that way and invited people to virtual forums where they could tell us about what they felt the biggest issues were in our community. And then we prioritized our issues, weighting both the quantitative data and the community input equally. And we did that in particular this time around because some of our health statistics you'll see come from 2019, sometimes 2020 data was available. But if we had just relied on that, we would have missed a pretty big thing that happened in our community in 2020. And so what people were telling us in the community captured the full impact of COVID-19 and what they were dealing with right now. This is the framework that we use to organize the report, and we also use this to think about how we identify what people's real needs are. So we don't just identify health needs as things like heart disease or cancer. We try to think about what are the issues and things that lead to those health problems that we can address before they happen. So we start on the right side of this diagram with morbidity and mortality, which is just death and disability, and the kinds of health conditions that lead to death, disability, and prevent us from having the long and healthy life expectancy that we would want. Then there are two different kinds of causes for those health conditions. There are health behaviors, things that we do, smoking, exercising or not, using alcohol and drugs, things like that. And then there are the living conditions of the places that we live. And we also refer to those as social determinants of health. So those are things like our built environment, the physical environment, our economy, our access to resources, and those kinds of things. And then this year, we also layered on an equity kind of lens. So those are the things that lead to poor health outcomes. They are also the things that lead to differences between groups. So they're the reasons why certain groups of people are more healthy and certain groups of people are less healthy. And so if you look at different groups by race, gender, sexual orientation, age, geographic location within the county, they may have more or less access to resources and more or less kind of exposure to things that would help make them healthy or unhealthy in the community. So we wanted to think about those differences when we put together our data. Overall, as a county, we are quite healthy, especially compared to the rest of the state. So we rank in the top quarter of the counties in Pennsylvania for overall health outcomes. And our life expectancy is longer than the state overall, 2 years longer. We also have fewer people that report that their health affects their daily life in a negative way, so that's positive. But then there are differences in different parts of our county. So the map shows the geographic distribution of life expectancy in the county. So the blue areas are the areas that have longer life expectancy. The pink and red have shorter life expectancy. So in Lancaster County, we're looking at, in some places, a 20-year gap in life expectancy between places that are just 20 to 30 miles apart. And then on the slide, we have life expectancy by racial group. And again, there are big differences there. So almost a 10-year difference in life expectancy between Asian individuals in our county and Black. These are the top causes of death in Lancaster as of 2020. So this changed for the first time in 2020 after many years. Heart disease and cancer have been at the top of the list for a long time. And then COVID-19, of course, was a new cause of death that year. It's very likely that that remained in that third position for 2021. That data just isn't available yet. And then some other things on this list are chronic diseases, diabetes and stroke. Those things have also been on the list for a while. Unintentional injuries is in that fifth place, and the two main things in that category are motor vehicle accidents and drug overdoses. For children, by far the top causes of death are complications of labor and delivery and birth defects or congenital malformations. Accidents with suicide are third and fourth, but those are much lower. And then this slide is health conditions for adults in the county. And this shows the percentage of people who experience these conditions, estimated number of people then that affects. And then the yes or no is whether we're in the top half of the counties as far as how we perform in Pennsylvania or not. So the ones that are no, that means we are not in the top half of counties in Pennsylvania. So at the top of the list, this probably makes sense based on the fact that some of our highest causes of death are heart disease, stroke, and cancer. High cholesterol, high blood pressure, and obesity affect more than one in, well, not more than one, about 1 in 3 adults in Lancaster. And then the next 3 conditions on this list may not necessarily lead to death, but they're important to think about because they have a strong impact on quality of life. So we have arthritis there, poor mental health, and then asthma. So you'll notice that the ones where we are the only ones on this list where we're not in the top half of the counties in Pennsylvania are asthma and then sexually transmitted diseases at the end of the list. Children in general have fewer health conditions than adults, but mental health is at the top of the list for them. So more than 1 in 3 children says that they were depressed or sad most days in the past year. That comes from a survey that's 6th, 8th, 10th, and 12th graders. So it's kind of like middle school, high school age. Then again, asthma is near the top of this list, and we are performing poorly compared to the rest of the state. And then obesity also shows up here with children, just like with adults. So I'm going to skip a bunch of work then. If you're interested in the prioritization method that we used, that is in the report, and you can look at those details. But when we took everything together, these were the top 3 priorities that we kind of grouped different topics into. So healthy environment, healthcare access and quality, and then mental health. And we'll talk about each of these and some key statistics for each of them. So in a healthy environment, we think about that very broadly. It's the built environment, it's the physical environment, it's also access to resources that you have in your neighborhood. Lead is a big issue in Lancaster County. So when we think about safe, healthy housing, lead poisoning is something that you prevent by taking the lead out of the home. But in Lancaster, because we have a lot of older housing stock, we have more than 100,000 housing units that are at risk for having lead hazards. We have very poor air quality. We actually rank in the top lists across the country as far as poor air quality because of our particulate matter. There are several reasons for that. Geography, factories, wood-burning stoves, agriculture. We also think about our bicycle and pedestrian infrastructure in this section, and there's a system of rating of how friendly roads are for bicycles and pedestrians. And so many of our roadways, the majority, are at the most uncomfortable rating for bicycles across the county. And then we have a lot of places where sidewalks are missing, that network is fragmented, and we could use improvements in our bicycle and pedestrian infrastructure. And then the last 2 are about access to healthy food. So we have a lot of people in the county who are low income and don't have access to a grocery store nearby. And we also have a lot of adults and children who report that they don't have enough food for an active, healthy life, that their food budget runs out before the end of the month, or that they're skipping meals, things like that. When we think about healthcare access and quality, there are also a lot of things that go into this category. So insurance access is an important one, and that's one, again, where Lancaster County performs poorly compared to the rest of the state. We have a higher rate of people who are uninsured. We also have fewer healthcare providers in several different categories per capita compared to other places. And that number has been increasing, but it's that we can't keep up with the population growth, basically. Then we got a lot from our community survey about healthcare access, and people were mainly concerned about the cost, that access to insurance, and helping people navigate systems. Like, it's too complicated, I can't figure it out, I have to worry about my insurance, and you don't talk to each other, and blah, blah, blah. And then when we stratified the survey results, we also thought that was important. When we looked at the responses from just the Black and Hispanic or Latino respondents, they rated increasing the diversity and cultural competence of providers as one of their top 3 issues. And then mental health. So this is the 3rd priority. And some of these things I've gone through already, but we have a significant proportion of the population not even accounting for the 2020 and 2021 data, so pre-pandemic, a lot of people who were experiencing depression or sadness or stress or anxiety and would rate their mental health as not good at least one day in the past month. And then we've also seen, even though I said that mental health is sometimes a quality of life issue and not always an issue that shows up in causes of death, we have seen drug overdose deaths and suicide deaths increasing. So I just talked about the problems. Michele and Alice are going to tell you what we're going to do about it. But if you are interested in the entire report, it is on our website. WellSpan has a dashboard that looks just like ours on their website as well, but this is the link that you can get to the report and lots of data if you're interested in keeping up with health data.
All right. I'm sure you have lots of questions. It's just, we can take probably 3 or 4 hours. So I'm going to go through knowing that this information is all available to all of you, and we want to be able to make sure we have enough time for questions from all of you. So write those questions down you had for Brenda. She's all ready to answer. Thanks again. And this information is all available publicly on our website. So hi, everyone. I'm Alice Yoder. I'm the Executive Director of Community Health at Penn Medicine, Lancaster General Health, and I'm really grateful to be here, so thank you for inviting me. And happy to present the highlights of our newest community health improvement plan. As Brenda mentioned, it's now a requirement based on the Affordable Care Act from 2010 for all nonprofit hospitals to conduct a needs assessment and also develop a plan in response to what we hear the needs are. It's a tricky thing to do. It's not real easy. It's great to get the community input that we get in order to help us with priorities. Because what we struggle with a lot is we can't do it all. So how do we pick these priorities and particularly activities of how we need to respond to what it is that we're seeing? And certainly learned over the years since we've been conducting needs assessment prior to 2010 with the community, and that's the key. So the whole key, I think, to a lot of the work that we've done over the past is the great collaboration and the ability to work with others, because there is no one organization, when you look at all these issues, particularly when you think of social determinants, that we're going to be able to tackle on our own. So please keep that in mind as I move through this. This Community Health Improvement Plan, which we call the CHIP, which is always confusing because you've got all these acronyms and you're thinking of CHIP and you might be thinking about Children's Insurance Program. But that's what we do in healthcare. We have acronyms. So this will take effect. It started July 1 and it'll go till the end of June in 2025. Several of the initiatives that we may have had in the last Community Health Improvement Plan, they also roll over. So it's not as if the last one, if you look at that and look at our final report, we're not checking the box saying, yes, it's done and let's move on, like we solved the mental health issue, and so let's forget about that and move on. So think about that from a realistic perspective. As Brenda mentioned with several of these, that some of the principles that we used in developing the Community Health Improvement Plan, these are the three key ones where we want to make sure that we advance health equity, we focus on preventing issues from happening in the first place, and we utilize evidence-based practices to address those needs whenever available. That's a key priority. Our other approach is our goal is to ensure that each person in Lancaster County has an equal opportunity for good health, and that takes different strategies and tactics. As the example up here with a bicycle, if we want people to start being active and riding a bicycle, we don't give them all the same bicycle to do. We have to have a different approach. And that communities most affected by health inequities must be our first priority, and that's what we've looked to do in this plan. Okay. So this slide is very, very complicated. I usually spend a half an hour when I talk about this, but this is the same very clear slide that Brenda showed earlier. And the point that it makes is this is the upstream approach. So we drew a stream and showed that typically when you think about healthcare, healthcare accounts for 20% of what makes a healthy community and what creates health. So all of that we're talking about in the role of a hospital is about 20% of what really leads to life expectancy and all those other goals that Brenda mentioned. So that's what this depicts, where we can be at the bottom with our hospitals and our ambulance and start pulling people out of the river, which is death and despair, or we can start going upstream where we address healthy behaviors, and better yet, we go further upstream where the clouds are that really speak to what are the social determinants of health, and that, that's a lot of the work that needs to be done. And the physical and social conditions where people live, where they're born, where they live, where they work, and where they age, is really important when we start thinking about strategies and particularly working with our partners. In terms of our approach, we have also evidence-based practices, as I mentioned, and there are three key sources that we use from a national standpoint to identify these evidence-based practices, and they are the U.S. Preventative Task Force, also What Works for Health from the county health rankings, and then lastly, Healthy People 2030 are our key sources that we look for when we start thinking about how are we going to address these issues. As Brenda mentioned earlier, these are our three key priorities. If you have a chance to look at our Community Health Improvement Plan, you will note that there are 8 goals, 48 objectives, and 10 additional activities that are beyond the 3 priorities that have are up here. So what I'm going to do is I kind of picked and choose a few that I thought were that I wanted to highlight out of the plan that are in each of those categories, because I wouldn't have enough time to do them all. So moving on into our first priority, which is around safe and healthy environment, and particularly focusing on, again, one of the social determinants of health, which is food insecurity. So in an effort to deepen our commitment to address food insecurity, we piloted a food pharmacy program in 2019 and expanded it in 2021. The pharmacist in this case is, guess what? It's not a pharmacist, it's a dietitian. And the medicine in this is also healthy foods. So that's what the food pharmacy is all about. It's a dietitian, and the medicine she is pushing is healthy food for those people that do not have access to it. The goal of the program is to improve biometric risk factors such as BMI, blood pressure, and hemoglobin A1C for patients with food insecurity and chronic disease, and also are income eligible for the program as well. In order to conduct this program, we partnered with existing food pantries. So all the education takes place at 4 of the current food pantries in Lancaster County, so we didn't recreate the wheel, and we work closely with those partners. And to date, we've served 388 people and have an overall 60% improvement in biometric outcomes and 76% improvement in behavioral health outcomes. And this year, we're planning to expand to 2 more food pantries, and again, working with pantry partners. The second initiative that I'd like to highlight in the first priority is focused on reducing lead poisoning. This presentation, of course, is not meant to do a deep dive on any one issue. There's just not enough time, and as you can tell, I can speak pretty fast, but that's not always effective and the best thing to do, so I'm trying to slow down right now. But we really have been finding that so many people are unaware of the significant lifelong health impacts of lead poisoning when children are exposed at an early age. It's still something where people think, really, is lead still an issue in our community? I'm amazed that that's still something that people don't know about, and so really the education piece is a big part of this. But primary prevention in this case, again, going upstream and not just putting Band-Aids on everything. We find out that homes built before 1978 may very well still have lead in them after all these years. So it's the home that's making the child sick. So then what's the treatment? The treatment is to get the lead out of the home. So abatement and remediation of lead for the children is the best thing to do. So Lancaster General has committed $50 million to remediate lead in 2,800 homes. We estimate that's what we can do with $50 million, and specifically focused on Lancaster County. We launched this initiative in 2021, and so far we have either remediated or are in progress of completing 180 homes. And also working very closely with the city's project. So I think a lot of you are probably familiar with the city had been working on lead for many, many years through several HUD grants that they received. So we're working in tandem with the city, and there's no wrong door. If someone contacts our program, we refer to the city and vice versa. So it works out very, very nicely. The next priority is healthcare access and equity. And this is an example of a priority that we've had in our CHIPS for almost every year that we've been doing community health improvement programs. As you can imagine, this is sort of your basic health care, but we're always looking from an equity lens to find out where people don't have access to some basic screenings, such as mammography, and what are those barriers, and how do we remove those barriers. A most recent example of looking at this, for years we've had clinics located in some of the poorer schools in the school district of Lancaster. And just recently, just before the pandemic, we expanded to McCaskey High School. So again, to look at some of the issues and how we need to improve what we're doing, we look at a different way of doing it, and that's when we expanded to McCaskey. The second initiative I'd like to point out here that I think is awfully exciting, again, it's working with lots of community partners. It's a program that we're calling Sidewalk Doc, which some of you may be familiar with the term used nationally, which is street medicine, and we just didn't like the term street medicine. So we changed it to Sidewalk Doc. And basically what this is working with, as you know, many partners are out there for years and years and years, working with how to address and meet the needs of people that are unsheltered, caring for people that are experiencing homelessness. So we have been working with them for many years, and what we identified as a gap is there are people that are out on the street and refuse to go inside for any reason and for anything. And that includes health. So we do have some people that are experiencing homelessness that will go to several of the clinics within Lancaster City and in the rural areas as well. But there are people that refuse to go inside for anything, and that includes food, and it includes healthcare. So the Sidewalk Doc program, we partnered with Water Street. We have a physician and a nurse that goes out on the street and actually assesses people where they are, and we also treat them where they are as well. That's a very new program. We just started it about 4 or 5 months ago, so we're still doing some tweaks. And then we are planning to expand it as soon as we sort of get those processes underway and expanding it beyond the city. We started in the city, but we're certainly, many of you that are out in the rural areas know that homelessness happens there too. So we look forward to expanding it out further in the community. The third priority is around mental health and well-being for the people in Lancaster County. And this has been a focus area for quite a while. I think in 2014, Lancaster General had made a major commitment understanding that a lot of work needs to be done related to mental health. And we began our planning of the importance of having a behavioral health hospital, a freestanding hospital within the county. So we were on that journey, and as you all know, there's a behavioral health hospital now on Harrisburg Pike to address those needs. But another piece that we felt was really important was what happens in the primary care office. So what we did at this point is we worked with other community partners that are experts in mental health, and we formed a coalition called Let's Talk Lancaster, because we just weren't talking about it. So isn't that a creative name for a coalition? So let's talk. So that's how we get it. And we didn't pay like a consultant to come up with that name, you know, and so that was a good thing, right? It was like, we could have, and I'm sure they were willing to, but it was pretty clear. We need to start talking about it, get our heads out of the sand, so then that will help people get assistance and help, particularly our younger folks too. So the other thing that seems like it would be easy, but it is not easy, I can tell you, is when the primary care physicians came together, and this includes all the health systems that are in Lancaster County, they looked to find a way to screen everyone that goes into the office. So hopefully all of you, when you go in to see your primary care in Lancaster County, it doesn't need to be Penn Medicines, that they should be asking you about anxiety, depression, and stress. So that is what we started organizing a little bit before the last CHIP, and we're increasing that. So first we had to embed it into our electronic health record, and I can't take a whole lot of time to explain how difficult it is, but I am a person that sprinkles the fairy dust, and that does not happen in IT. And I learned that pretty easily, and my IT folks always yell at me. It's like, it's not that easy, Alice, it's gonna take a while. So not just impatient, but just imagine, first we have to get it embedded in an electronic health record so it's asked on a regular basis and it's documented. But then also, what do we do with that information? That's what the primary care physicians told us. Okay, we can screen, and we know what the answer is gonna be, so what do we do with it? So we had to set up a referral system as well. So not only ask the question, but when we ask and people tell us that they have a level of anxiety, depression, and stress, then we make a referral. So that was over the last CHIP, and then towards the end of the last 3 years, what we ended up doing that we felt worked the best for our primary care practices at Penn Medicine, Lancaster General, is to embed counselors in the practice. So we refer to other specialists in the community, depending on how people respond to the screening, but we also have counselors in all our primary care practices. So then from a stigma standpoint and from a normalizing mental health, when you go into the practice, when you think about you're going in there for a physical need, but there's also a mental component of it all, it's all located because it's all connected. The head connected to the rest of the body, and it's a better thing to do. So that's what we've done over the past 3 years, and in the next 3 years, where we have most of our counselors also trained in special trauma training for people that have experienced some trauma, and we're going to enhance that. This next slide is an example. I can show you a lot of slides related to this and how we measure, but I thought I'd throw in one that seems kind of technical. And this is actually one that the Let's Talk Coalition, the primary care providers, use to measure what they're doing. So 2017 is when we started looking at depression screening in the practices. And there were several practices in our community in Lancaster County overall that were already doing the screening. It wasn't standardized, it wasn't the same tool, and they didn't ask it all the time. But we started out with a baseline of about 38%. And then over the past years, we've increased it up to 58%. And this year, we have a goal, that group has a goal of increasing it by 4% more in terms of conducting the screening and then making the referral. But I just wanted to toss this one in here as an example of what we do. And so I mentioned trauma, and so the whole idea about trauma-informed is really important. Brenda mentioned a little bit of it, but if you're not familiar with it, Again, I can't go into great details, but it's all based on adverse childhood experiences, which includes emotional, sexual, physical abuse, violence, neglect, discrimination, poverty, and other adverse experiences. And ACEs really has a major impact, lots of research out there that the potential for increasing health problems and the individuals that have more ACEs are more likely to engage in risky health behaviors as well. So really strong evidence that all of that is connected. So with that being said, one of the initiatives we started and we're expanding is around training for trauma. So we have several members of my team that are experts in trauma training and education, and that is available thanks to several grants that we received to be able to provide that in the community. And we are working with, as you can tell from this slide, many sectors to think about how to be trauma trained. And so the second part to this, which is super exciting, is the Mayor Sirachi has basically come out and said that she would like the departments in Lancaster City to be all trauma informed. And so there was a grant that Lancaster County received, and specifically for the city, where we're able to increase the training and technical assistance. So we're working in partnership with the city to do that with all the departments, and it's been really amazing. But we are working with a lot of other sectors in our community, including the Housing Development Corporation, that work with individuals that are in low-income housing. And so how their staff relates to those individuals, when you think about people that are in that lower income bracket that maybe have some housing insecurity, more than likely they've experienced some adverse childhood experiences, and how we approach them and our techniques and all of that do matter. And they're all committed to it and making some changes. The neat thing I love about where we're going with this is one thing, and this is probably in some of your minds. I'm looking at you, some of you, and I know you, and you're thinking, okay, well, it's great to train, it's great to educate, but then what? What next? So basically what we're doing is providing technical assistance, and we're working with the different sectors. So for example, the Housing Development Corporation, as well as the city departments, to actually look at their policies and practices. So once they become aware of what it means to be trauma informed, and then they think about how they do things, they think about how they can change the way they approach people and what they do, and make it a systemic change in their policies and practices within their organization to be more trauma informed. And that will be lasting, long lasting is the goal. It becomes a systemic change. And then the last part of the third priority that again, I had to pick only a few. There are multiple things we're doing within the area of substance use disorder. Hopefully many of you have heard of a coalition called Joining Forces. That started in 2017, and it was focused on reducing deaths from opioids and heroin. It's a major collaboration with organizations that have been working in the substance use area for a very, very long time. And so we've made some progress for a while there until the pandemic hit, and now we have some other issues where we need to gather again. But one of the things that we discovered is that there is some attention on children, but there wasn't a whole lot of attention. So actually there was another coalition that formed just before the pandemic hit, and it's called Joining Forces for Children. So they took the adult version, did it for children. One of the programs I want to highlight that's part of Joining Forces for Children is called Handle with Care. And that program is a trauma-sensitive approach that allows law enforcement to notify early learning programs when they encounter a child. And that can be a child that's part of a drug-related incident, or it could be a child that's part of a car accident, or when a family lost their dog and they call the police to come find their dog, all of that, or a part of a fight. And the child is actually part of it, and it's observed, and law enforcement comes to the scene. Well, what the Handle with Care program does is that then law enforcement contacts the early learning facility and just mentions that the following day, so the incident happened one day, the child's going to school the next day, law enforcement contacts the school and basically says, handle with care. No information about what happened is shared with the school, but what the school does is they have a protocol to work with that child differently on that day than they would have before that time. So currently we have 11 public school districts that are participating. 11 of our school districts are participating. 5 non-public school districts are participating, and 43 early learning classrooms are participating with Handle and Care. And we're following that program again for more years, because there's still lots of needs to expand what's happening there. And the last program I'd like to mention and highlight as priority number 3 is that, as I mentioned, we've had the Joining Forces Coalition for quite some time. The data that we've been able to receive from the state and that we have locally has improved significantly compared to earlier when we were looking for data to see how are we doing, and then to develop tactics and strategies to address it and prevent people from dying. However, we feel like there's more information missing. And so across the state, and particularly in other states, there is a new team that's developed by counties called Overdose Fatality Review Teams. So this is hot off the press. We just received a grant from the state to think about implementing one here in Lancaster County. Penn Medicine, Lancaster General Health is taking the lead on coordinating this effort. Actually, Brenda, sitting right here, is the main coordinator at this point. So the purpose of the overdose fatality review is to identify new gaps. So it's pulling that information together. It's getting more detail about the family and about, did they go for mental health counseling? Were they seen in the emergency room prior to this? What led up to the death? So we can understand and get more information about what we need to do differently to make a difference to prevent people from dying. So that's what we're excited about, the overdose fatality review. However, not to get too excited, I happen to be a pretty big optimist. So we're hoping we can get good information, but as some of you sitting around here are very aware of, between mental health and substance use, there's a lot of laws and regulations about sharing information. So it's not easy. It's not going to be easy to do. There's going to be barriers up. But we're coming together just to try it because it's worth it. Because if we can save a few more lives by going through this process, that would probably be a really good thing to do. So stay tuned. We're still spanking new, so we're going through the whole process right now, and hopefully you'll hear more about that. And if we don't get good enough information, we're more than likely not going to do it, because if we're doing it so we get better information to implement something to prevent more deaths. Otherwise, why are we sitting around talking about something when we can't have really an impact with what's happening? And last but not least, I wanted to bring up an example for one of the additional initiatives, which I think is amazing and should be is near and dear to my heart, because I really do feel like physical activity, we know, is a really important part of everybody's life. And sometimes, we think about these other issues, and they're all very important, but if we get back to some basics in terms of improving overall health, people being physically active as any way that they can is extremely important. So we've been on this journey with various partners through the community for many, many years. We're big supporters of Rails to Trails and any way we can connect communities, complete streets ordinances, and how we can connect one suburb to another suburb so people can get out for a walk and exercise pretty easily, and it doesn't cost much. So again, looking at the equity piece to all of this. But we're very excited about this new initiative. So we're collaborating with the Lancaster County Planning Department and other partners on the Heritage Pathway. And I think there's been some things in the newspaper recently about this, so hopefully you're very familiar with it. So this is a new trail that they're starting to pick miles and miles, kind of tick away at connecting all of it, starting in Leola, going through Lancaster City, and then ending on the west side at the Lancaster General Suburban Outpatient Pavilion. And so we're really excited, and we have committed financially and in planning support to have the trailhead located on Good Drive across the street from Women and Babies, where the old child care center would be. We've allocated the location, we're coming up with the design, and all ready to move on that one. And we feel that it's really good timing related to physical activity, and because we really do think there's, between all of us, look to your left, look to your right, I don't know how many people I talk to, there's just a greater appreciation for how being outside affects your mental well-being. During COVID, we found that for many people that really didn't do it before, it was a refuge for them. So the benefits of not only being physically active, but being outside and being physically active, and also the sense of nature. Because if you're familiar with the Heritage Trail, it's going to also have a lot with the conservancy and water and all of those other things that really lead to a very peaceful way if you wanted to take a walk and then decompress. So for a lot of different reasons, we're excited about this trail and have committed to that in our new community health improvement plan. And that's it. So thank you. I look forward to questions later on. Thank you.
Okay, so I'm Michele Mummert. I'm the Senior Director for Community Health for WellSpan. Really pleased to be here today. Many of you might know Steve Batchelor. He's a colleague of mine, and he's on some much-needed vacation this week. So happy to be here and share a little bit about what we're doing at WellSpan. And if you walk away with anything, I hope it's that the work that we're doing is very congruent and aligned with the work that LGH is doing in the community, and that, you know, collaboration, partnership with all of you, with the health systems, you know, that's the way we're going to be successful in improving the health of our communities. So a little bit about the work that we're doing at WellSpan. So our community health needs assessment, outside of the one that we partner in Lancaster County, it really consists with the health needs of residents living across our footprint, which is Adams, Franklin, Northern Lancaster County, primarily Lebanon, and York County. So what we've learned is that the variability across these regions is, while there's some unique assets and characteristics of these communities, overall, there's not a whole lot of variation between the community health needs. I hope that, you know, you'll see that consistency sort of in the information that I share. But our needs assessment and our needs assessment and our community health improvement plan are available on our website. It shows you here how to access. And our community health needs assessment is a large report with a lot of data. And then our community health improvement plan is our 3-year plan to address those priorities. So our report is based on methodology that includes both primary and secondary research that we do. And we collected our primary data survey in both English and Spanish. And we looked at birth through advanced age for the individuals that we got a representative sample of the community. And then we coupled that with extensive secondary research, looking at, for example, U.S. Census Bureau, Department of Health. And then we also this year had enough data in our electronic health record system. So some of the questions we asked in the past, we actually could get a representative sample from our own patient health record, looking at reports collectively. So, you know, this process, you know, really focuses around one core question when we do our community health needs assessment. And that question is, what are the most pressing health needs affecting the health of our community? So when we do the needs assessment, that's our core question. And then when we do the community health improvement plan, we ask, what can we do as WellSpan in partnership with other health systems and with community stakeholders to address those pressing health needs so that we can advance the health of the community? So when we look at this, we see some key themes this year that were unique, not surprising. It wasn't just the impact of COVID, though. What we saw was the experience of living through a pandemic was unique to everybody in our community. And we saw widespread trauma, anxiety, and mental health challenges faced by our neighbors, our patients, and our own staff. It's not any surprise to probably any of you that we experienced unprecedented upheaval of how we navigate services, how we connect with people in our community, and how public health systems function. And so our patients and community members, particularly those that are most vulnerable, had even more challenges accessing and navigating their healthcare needs and social service needs. And, you know, as Alice talked, only 20% of a person's health is really impacted by care. So when you think about that social impact, it's huge. And then you throw in the effects of the pandemic, the social isolation, the grief, the exhaustion that everyone felt. You know, it created not just individual trauma, but sort of a community level trauma. So when we think about the pandemic and how it exacerbated those existing challenges we faced in the community, you can almost think of it as we're dealing with a community in a recovery phase as we look in the next 3 years. And then, you know, as I reflect back on the pandemic, I'm really proud of our WellSpan team and how there were certain areas that we could accelerate our strategic plan and really lean into some of the ways we cared for the community. But while we did that, there were all of these other needs that that were exacerbated by what people were experiencing. So some of the factors that we saw sort of rise to the top when we did our needs assessment were people were delaying care, the effect on childhood development, people not practicing healthy behaviors, so their chronic illnesses, became worse, and then that increased social determinants of health barriers in the community, and the gaps that we experienced in our public health services and infrastructure. So, what I'm going to talk about here is just a few of the key highlights or conclusions based on the data, rather than share the deep level data. So what we saw were that many residents in our community delayed that preventive care. At the same time, they participated less in positive health behaviors. We saw that racial ethnic minority residents are more likely to be uninsured. They experience a higher rate of food and housing insecurity, have more financial hardship, and they've experienced unfair treatment. By and large, our behavioral health indicators have significantly worsened for just about every age group in the last 3 years. And then we saw the rising economic inflation and financial concerns and how that exacerbated the social determinants of health barriers that our residents experience, particularly around food and housing. And then, one of those is just the housing cost strain for many of our renters. And then, there were a number of concerning trends related to the health of our children. Some of those were high rates of uninsured children, which was somewhat of a surprise to us, limited access to early education for low-income families, increasing rates of students that are eligible for free and reduced lunches. And what that tells you across all of our school districts is sort of that rising challenges with poverty. And then growing rates of risky behavior among our adolescents. So all of these identified challenges really aligned with what we learned in the last 2 years dealing with COVID, and particularly how we reside in a region where there's no county health departments by and large, and that sometimes that fragmented structure kind of makes it challenging for all of us to respond to some of the needs in the community. So what I'm sharing here, and it's a lot of words, and you can find this in our report, but this is our framework, and I'm not going to sit here too long. It's very similar to how Penn Medicine creates theirs, but I like to think about this as the umbrella is really around health equity and reducing disparities. We look through that lens. And then the floor is sort of the core principles for how we do this work. And then the left side is the structure for the accountability across the system. We don't look at this as WellSpan Community Health Department's plan. We look at this as the guiding mission work related to how we invest and partner with the community as a health system. And then in the middle, those 4 pillars are really our priorities, which is where I'll briefly run through quickly to talk about what they look like in the next 3 years. So Care for All really speaks to that access to primary care and also to addressing the delayed care in the community. And developing a strong safety net for our most vulnerable. So we partner with our federally qualified health systems and other charity care providers to remove those financial barriers to care and also improve access for our most at-risk individuals in the community. And then this is where we really speak to improving health equity by addressing those gaps in access to care, particularly our most diverse community members. And what I'll say here is we learned a lot in COVID. We did a lot of mobile COVID clinics, partnered with the faith community and our Latino population and Black communities, and partnered with organizations that had membership or clients that we knew couldn't maybe navigate the traditional healthcare system to get their COVID care. And what we saw is we were able to close that gap quite a bit in our racial ethnic minority populations. We took that learning relatively quickly and applied it to our mobile mammography, which is a service that we rolled out. And what we saw is, using the mobile mammography coupled with a lot of other work that we've done, we not only closed the gap, but we actually just looked at the data recently, and when you look at our Hispanic population, more people on record with WellSpan as a patient from the Hispanic Latino community have gotten their screening mammograms than our general population. So we were really able to flip some things based on the work and the learnings that we had in the last couple years. Mental well-being, this is a big one for us. And, you know, we really want to focus on building that mental well-being and resiliency in the community while we improve access to behavioral health treatment. And, you know, as a health system with a behavioral health, function or arm, we tended to be focused on treatment. And what we realized by looking at this data and what the community experienced in the last year is we need to go more upstream and really provide tools to individuals and groups of people and our partners who serve the community in providing tools to keep, to stay mentally healthy and focus on more of a well-being. We also do our substance abuse work under mental well-being too, and we'll continue our efforts to address opioid misuse, and we've been doing a lot of work with that. So we'll continue that, but we're also expanding that to look at other substances and how we can continue to provide addiction treatment and preventive messages around that. And social determinants of health is a big area of focus. In the next year, we're going to be really focused on helping people navigate and creating a system of care where there's seamless navigation between social services and healthcare. We're going to continue our work. We've leaned in heavy into food and housing insecurity, and those partnerships and that investment is really starting to show some results and create some stronger connections in the community. And then we'll continue to collect our data at that patient level, very similar to what Alice said, screening for social determinants and mental health well-being at the point of care, whether you're in the hospital environment or in the ambulatory space. And then healthy communities, we look at this as really building that capacity to support this work across all of our communities. We do that in partnership with a lot of coalitions, but we also added in an element where we want to really take what we learned about the public health infrastructure and how we've navigated that through the pandemic and apply that to really understand what our role is as a health system across the communities to support that work so that we're more prepared next time. Hopefully it won't be for a long time, that we have to go through something as significant as what we did as a pandemic. And then the other component of this, which is relatively new to our work, is really focusing on children. And we chose age 0 to 6 so that we can build up that next generation to be healthy and ready to thrive as adults in the community. So kind of going back to Alice's analogy of a stream, this is our way to say, hey, what can we do way upstream so that our next generation is really prepared and healthy when they're adults. So here's where we are now. We're asking ourselves as a health system, what can we do to take action? And when we think about what success looks like, we're really looking at the metrics and how we measure success. And partnership. Partnership is huge. We know we can't do this alone. We're not the food bank. We're not the housing authority. This requires a lot of partnerships. But what we use to guide our work is what we call the socio-ecological approach. So we know we can tackle these issues together as a community when we look at how we engage with an individual, how we engage with organizations in the community, and then all the way up to that policy spectrum. So when you put all of this together, that's when you really have impactful change around collective action. And then where we are today, we are taking our CHIP plan, which is kind of what we learned across the region, and we have been talking all along with our regional operations teams and leadership and subject matter experts and our community partners across all of our counties. But we're developing relevant action plans at that county level. and really trying to be local, coordinated, and impactful based on whatever those community assets are at that local level, and the energy and capacity of those community members to really drive this work forward. And we're trying to approach this about, when does WellSpan lead, when do we partner, and when do we just support the work so that we can create that socio-ecological approach. And at the bottom here, you can see some of our health coalitions that we really work closely with to drive that work forward collectively with our partners. So this is the work that's underway. Our approach is really focused on what can we do in fiscal year 23 that's very tactical, while we keep our eye on what we can do over the next 3 years across our community, and then impact change in the long term. So that's all I have for you today. I appreciate the opportunity to be here. I appreciate the partnership with Penn Medicine and Alice and team.
Thank you so much, Michelle. We probably have time to take a question or two. We're getting towards the end of our time. I don't know if you all want to join us up front, so if there's questions for any of you. And if you have a question or two from the audience, we'll just have a microphone so the folks on the live stream can hear you. If you'll just say your name and your question, start with your.
One of the foundations of be healthy is vitamin D. And as far as I understand, about 25% of the community is deficient in vitamin D, another 40% insufficient. And yet nothing in any of your plans talks about addressing that key issue, but helping people get the blood tests and getting their vitamin D levels up to where they should be.
Yeah, I can tell you that, typically when we put together, this plan, it's not that tactical, but that is definitely, when we look at access to care and connections to primary care, that's really where I would think that intervention would happen.
Yeah, so I guess the only thing I would add is that that's really good information for us to have. I think what we're highlighted and what we put in the plan are priorities. That's kind of similar to what I said in the very beginning, where we struggle with hearing that message and thinking about how many things do we do. So I think, to Michelle's point, at a very tactical level in our primary care practices in terms of screening people and then identifying solutions at that very level, I feel pretty confident that that's being done. And to think about your point and think about how we would take action on it, are you thinking that a broad campaign to increase awareness? I think we have done that at different times too, when we encouraged physical activity and being outside, and the importance of, I can't say, I don't want to say in general that I understand all the science behind why that's happening, but one of the assumptions would be that people are spending less time outside. And then you have mixed messages of when you're outside, you need to make sure you're protected from the sun. So all those really complexities of how our society has changed over a period of time about how we function could be the answer to all of it. But I think it's a great point and question. I'm certainly going to go back and make sure that we're addressing it at the primary care level.
Absolutely.
Thank you for coming. So Alice, on the lead remediation, the 2,800 homes, who identifies those homes, and then how is the process for selecting the people that actually do the lead remediation done?
Yeah, great question. So we have several strategies of how we're identifying the homes, and the big thing is we're getting the word out about the program. So it could be physicians are making referrals, so we're getting referrals from any primary care physician, particularly when they're testing a child and the lead level comes back elevated. Then we obviously have to ask permission from the family to go into the home and inspect it. So we have partnered with a group called Green and Healthy Homes, and they are working with doing the home inspection and then also doing the remediation. But this program is open to anyone, so it's getting the word out. And if you know people in your community that have a home that was built before 1978, that they need to be thinking about this. And then they can make the referral to the lead program, and then we take it from there. We have case managers that are going out and working with the families. We're staying connected with the families until at least the child is 6 years old and maybe older to make sure that that level stays low. There is an income eligibility component of the program, which is 400% of poverty, which we feel is pretty beneficial. The other thing I didn't mention is we also received an additional grant to work with 150 of the homes we have if we find other things that are in the home that we need to take care of, such as mold and some things related to asthma. Yeah, great question. So, yeah, that actually was our first home. Our first home, I think I can say this, I'm going to say it anyway. I think I can say this, I'm going to say it anyway. Our first home was our big surprise was in a rural area. And it was an individual that heard about the program, called us, and they're renting part of a farmhouse. That's actually the landlord is in the Plain community. They were Amish. So they connected with their landlord, then the landlord connected with us. And what the commitment we made is as long as the person living in the home has a child and they are meet the 400% of poverty, we will remediate the home. We're asking the landlord to pay 10% of what it costs to do that. So pre-pandemic, it was around $12,000 to $13,000 per unit to remediate a home. Post-pandemic, with the supply chain and issues, it's now up to $18,000. And we're asking the landlord to put in 10%, we'll pay the rest, but we're really focused on the child. Green and Healthy Homes Initiative, that's the name of the company. So it's initiative, but yeah, if you want more information about that, just email me and I can give you all that.
I'll just ask one question from the online viewers. I'll come up here so you can hear me.
Hi, thank you so much for your presentation. I'll just ask one final question from our viewers on the live stream. Their question was around the new Queen Street Flats apartment, which I know just broke ground this week, and the comment was access to housing is an important issue related to health. And do you think that there'll be any potential to see affordable units in that project?
Yes, my understanding, I don't know the specific percentage of those, how much is in that. It's at a minimum what the city provides.
Okay, great. Well, we'll be excited to hear more about that project as that develops. Thank you all so much for being here. Michelle, Alice, Brenda, we can give them a round of applause. That was a lot of information. And for everyone who's watching, we'll follow up with a video recording of today's session and also links to the actual assessments and the health improvement plans, so you can check them out for yourselves because there's a lot of great information in there. And I would encourage you to share a recording of today's talk with other people in the community who are interested in Lancaster's community health needs. Our next First Friday Forum, it will actually not be on the first Friday because that is Labor Day weekend, so go enjoy a picnic somewhere and join us on September 9th will be our next First Friday Forum. And that will be all about the new Lancaster Public Library that is coming to the city, which is a really exciting project. So we're looking forward to having them joining us. To receive invitations to all of our First Friday Forums, please become an Hourglass member. You can do that on our website at hourglasslancaster.org. And until then, have a great weekend and hope you can join us in September. Thanks.